As long as it's not scratch and sniff audio. Yeah.
Okay, so I sent the invite that's a while ago. That's with a draft concept from Stefan and Keith and myself, and we try to resolve a long-standing issue that's this issue has been raised many times, especially in our grant management. So when we have today, we're not talking about the size estimation. Like actually, that's what the quality and what methods this is about. It's the best basically when we have a size estimate already in the country, no matter what kind of method we used, and then we need to see that's which number we can really use for target setting and for our grant performance measurement. It doesn't make any like real sense. That's if we use this total size estimated. That's a as denominator for any grant. That's a we already see it from our grant report. The coverage, if we use that as denominator, the coverage is consistently low, and also that may affect this UNS estimation. I don't know this estimation process that when the coverage is really low, probably indicates something also on that. But the thing that's I want to put on the table, it may not be fair that's for our principal recipients if we put a big number there as denominator. Why actually that's we don't need to reach all of them, and some of them are not reachable, and some of them we may not. They may have access to other services. So this kind of complicated thing, and also this um, being mobile, and also that's volatile in terms of the behaviors may change over time. This from time to time. So that's a lot of complicated thing here. Toby, welcome back. This we already started. We already started recording. I hope you will be able to speak, but the thing you cannot unmute yourself. That will be difficult. So that more or less this the background. I will ask Keith. That's from Global Fund side, what we want is that something that we can tell our country team out of this total size estimated, what kind of roughly the proportion when during the planning stage and target setting stage. We can say, okay, out of 100, 50 should be used in the target setting process, or 70 or 80. If that percentage actually different across different regions, across different groups, and what kind of factors we should consider in this kind of process. Because this question always come to me at Global Fund. I do not have an answer. I never really have a good answer that's for that. It's very difficult that's to have like a even for the country specific generic one is not possible. That's even for the country specific discussion always challenging. So I let me just that's a very brief introduction and the keys piece.
Well, just in case deriving size estimates wasn't difficult enough, we wanted to add a layer of challenge to it. Yeah, we're talking increasingly about differentiated service delivery, so this becomes perhaps a more important element to consider in terms of target setting as well. And so we already do this to some degree in Asia, and within spectrum models that use the AIDS epidemic model in Asia, we have two categories of men who have sex with men, and we have two categories of female sex workers built into the modeling process. For female sex workers, it used to be street and brothel based versus entertainment based sex workers. But that devolved into higher risk and lower risk more generally. not strictly by the place in which a woman was working. It was a little less clear how the men who have sex with men disaggregation worked, but there was a higher risk group and a lower risk group within the models. And now, as we are moving to incorporate key population data in all spectrum models globally, including in Africa, we would like to be able to fold this into that process if we, one, we have to have the data, but two, if we think it's critically important. We know that there might be some men who have, one other male partner every 6 months or a year, and they're using condoms, but they're otherwise only sleeping with women as partners. Then you have other men who are in stable relationships with men, and they're not sleeping with other men. So while we use these proportions to come up with the total for a country, and we can do that perhaps by region or some other cultural factor that allows for outness and things like that, I'm not sure that could be applied if we wanted to differentiate into, say, two groups of higher and lower risk within the size estimate of the different key populations. I think we could get into this with people who inject drugs as well, more frequent, less frequent injection, or steady access to clean needles versus unstable access. But the question is, should we do this? Can we do this? And if the answers to those are yes, then how do we do this? Targets that Jerry worked on a while back, but that was focused on people who were HIV free, and looking at the risk factors for incident infection. But this would be people in need of services, both before they acquire HIV and after they acquire HIV. So it's a slightly broader set of risks that we need to look at, and additional considerations for us to look at. So that's my overview of it.
Yeah, I understand, Steph, that you have already actually put thinking into this. I don't know, that's before we open for discussion. I do have some items we need to discuss today. Steph.
Yeah, I mean, I'm happy. I imagine actually everybody on this call has put a lot of thought into this. I don't know that my thoughts are exceptional, but since you've opened the floor, yeah, I mean, I think, there is no doubt that there is a wide range of risks among gay men, among people who sell sex, either, from whether it be their full-time occupation or not, in terms of the dynamics in which they sell sex. And the same thing applies for drug use. I think I always say that, like, I work, I do research abroad, but I work more public health oriented in Toronto and in Baltimore. And there's nobody would ever suggest that we would reach 100% of gay men in either of those two cities. It's a much more nuanced approach in terms of, like, discerning between who you can reach and with what service. And so that may very well differ for, treatment outreach, where you really are aiming for 100%, whether it be through a variety of different types of programs, from PrEP, which will be definitely lower than 100%, because if gay men are stably coupled, they have zero need for PrEP, for example. And so, yeah, so I think this is an important process. I think from you guys, I think I have maybe different motivations than do you, which is natural. I think for you, it's about target setting, and for me, it's about, like, being more nuanced about how we understand HIV risks and transmission, and programming in general, and risk stratification as part of that. The only thing I really want to add, maybe practically, is that we see a lot in our data where we have prospective data about seasons of risks. and the sort of dynamic nature of risk. And that definitely applies to substance use. It also applies to sex work. And it applies to gay men. Gay men are stably coupled for significant periods of time and have very low risks, and then maybe not stably coupled, and risks may increase. And so I think we've tried to spend more time understanding the sort of dynamic nature of risk, but it all speaks to the sort of the need to be more thoughtful and nuanced about how we stratify risks as a means of informing the denominators of different programs. And I think that's all part of this natural process. I think you said at the beginning, if it wasn't already complicated enough with doing better on size estimates, et cetera, but it's like it all feels like this is part of a process of being more nuanced and thoughtful about how we plan and program in the HIV response. So thanks for the opportunity to share some initial thoughts.
Thank you. I think that the request is from me because I have I'm facing this big problem that's every day. So I need to have something. It's not whether we can do it. My request to you guys, we must do something here. So we need to come up with something that's to answer that practical question. So my request here is to have some kind of percentage of what I said earlier. This is 70%. I would say there's two categories. I don't want to make this multiple categories. Probably for more nuanced, this link with service, that is need to be more nuanced. But for global fund side, we propose something called a minimum package of service. It's very, very, very simplistic. Just risk reduction, the first one. The second one is commodity, like condom, needle, or that whatever. So depend on which group. And the third item in the minimum package is referral. If you need to have some service, because they want to make this more generic in terms of that. So keep this in mind when we try to set target, it's more like against this kind of minimum package of service. Of course, when we come back to this real service implementation setting, that's we will need to more nuanced differentiation or strata against each of them. So I hope it's clear my request. Let's open for discussion. That's what factors should we consider, and something that we can really, to what extent we can do. It's not whether we can do, but to what extent we can really do something. Open now. Anyone can say anything.
I could share some thoughts based on the PrEP guideline, which had a lot of the similar challenges, but as Keith mentioned, and as maybe everybody knows, because a lot of you helped, the challenges were similar. Like it was a similar conceptual question. What is the size of each population at risk that should be considered targetable or within a target for PrEP? So even though it was just among HIV negative KPs, the rest of it was similar. How many or what proportion are worth going after because of some behavioral risk factor? And then that coupled with, are they in a place where there's enough risk? Those were the two dimensions. The individual level behavior plus what's going on in their context. And the context, that element was really pushed by the advisory committee. I think all of you, well, Stefan, I know you were on the committee, and then Sharon, I don't know if you were on it. No, but Stefan was certainly on it. And from that committee, my first attempt, which was just based on individual risk behaviors, was shot down because there was a comment that you have to take into account the background prevalence, the background percent of people virally suppressed, etc. Because if you're in a place where prevalence is low and VLS is high, then you don't really need to worry. So I guess a couple of thoughts from that process was, in looking back over some analysis that I did, that's in this long appendix to the guideline, I see that the percentage of MSM, for example, that would be classified at risk according to different criteria varies a lot. varies a lot from city to city. We had data from 5 cities in this table I'm looking at, 1 in East Africa and then 4 in Latin America. And unfortunately they vary a lot. So that gives me a gut feeling that it might be difficult to define a universal percentage or even a region-wide percentage. But what about, would it be good enough to give guidance in terms of criteria? For example, you could provide guidance to say, okay, we're not sure what the percentage is in your country or in your region, but consider targeting all MSM or sex workers who meet, these 1, 2, or 3 criteria. And that could allow maybe for the nuance that Stefan has mentioned. That's what comes to mind at the moment.
Sorry, that's Wolfgang will come to you. For this aspect, that's from my side, it is difficult to implement unless we have provide this data that's for the factors to consider. So either they're from this IBBS in the past or some kind of problematic data that's there. If we do not give something that's do the analysis together with them, people will come with much lower percentage. That's a natural tendency for PR, for our principal recipient. So we'll come with that's because they want to, their ground performance look very good. It's always the kind of tricky thing. But the thing, this is good. That's a very good consideration. That's I understand the difficulties come with actual percentage, and even a range can be useful. Like a MSM, this 1 to 4%, that can be useful still. Thank you. That Wolfgang.
Thank you. I don't think I have an answer to offer here, but I do have some thoughts. So I want to share this with you. Currently at the Global Division for HIV where I work, PEP4 CDC, the most favored size estimation method is capture-recapture, especially 3-source capture-recapture. And within that, the most favored way of doing it is to use unique object distribution in venues, ideally twice, and then the third capture would be a survey, for example, an RDS or a similar BBS. It would be very hard to collect any information during the unique object distribution that would allow us to guesstimate what proportion may be at higher or at lower risk, because these encounters are brief. In the RDS survey, that would be much easier. At the same time, I think without discussing this a lot internally in my branch, I think we generally assume that our size estimate relate to MSM or to female sex workers at risk. We just assume them all to be at risk. And maybe this isn't, maybe this isn't such a soft assumption if, because we do think for someone to show up in an RDS survey or to show up in a venue might already be some marker that might be related to risk. On the other hand, when I hear you, Button, about reach and coverage, maybe that's another approach to look at it. What portion of the MSM can be reached irrespective of risk? What I'm trying to get at, for example, programs often do not cover every town, and of course we can't assume that MSM are only living in towns. It seems like they're also living in villages where our reach, I think, is very limited. Then I think that the document that you shared from staff may already get into this. There's this proximal risk, maybe social network-based risk, distal risk. So how is that defined? And is this proportion, if we would even get to a definition, can we assume that it is stable across time and space, or might it maybe a simple approach that might only work for MSM is maybe to think about a fixed proportion of adult men being gay or MSM, and whatever PSE we come up with is the proportionate risk, and the remaining one is at lesser risk. Yeah. I mean, all not very satisfying thoughts, I think. Yeah. Over.
Thank you. I recall this discussion with you and there's also on AGYW. That's when we try to define this, what the higher risk districts where we should target, but never really move to the individual level. That's is still a big step that's in between. I do recognize what you mentioned about this size estimation, different methods. Should we consider the method itself and then for the proportion of that, and for sure programmatic mapping and capture recapture or the RDS best or simply there's a multiplier, probably they can be different. I don't know. That's a put more thinking into this while you're talking.
I was actually wondering if there was some way we could look at this through social network properties and try to understand the distribution of risks out of particular nodes. You have usually higher risk individuals will cluster in the social network, and the risk will start to diffuse as you get further from those nodes until they reach another node of higher risk. And I'm wondering if we can look at the proportion of high risk edges versus lower risk edges. Something, yeah, we invited Ian Fellows to this, but he wasn't available. But that was, you know, I'm just speculating here on what might be possible.
Yeah, unfortunately, Ian, he's on leave. He's on leave. That's we didn't invite him.
Yeah, it's the end of July.
Yeah.
Yeah. Well, actually, Sharon, I've already spoken, so I'll go after Sharon. That's okay.
Okay, Sharon.
Yeah, I am just finishing up a big study in Blantyre where we compared risk among people who are going to the clinics, where you would have, you know, clinic-based information, and people at venues, including, you know, everybody who goes to venues. And when you talk about who's more at risk versus less at risk, among our female sex workers at the venues, you know, about half were infected with HIV, but of those, you know, 85% or so were suppressed. So they're not at risk anymore of acquiring or transmitting, at least in the short term, but you'd want to have them in your targets for your coverage. I mean, you'd want to say those people need to be reached with their treatment services. So I guess for me, I'm having a question about what do we mean by what percentage of these key pops are at risk? You don't really mean at risk. I think you mean what percent need to be reached with what services. Is that right?
Yeah, that's what I mentioned. That's very beginning for global fund. That's only global fund grant. That's we have the minimum package of service. Of course, this you can understand risk reduction. There can be a lot of other things, and also referral. There's a list of items there. There's a referral services. For this nuanced piece of segment of the population for different services. Probably at a country level, we need to really discuss about that. But for at a global fund, the global level, so that's something that's we'll need something like maybe arbitrary, maybe like but with clear understanding of caveats. And that can be very useful. So Sharon, let's stop you. That's if you continue.
Oh.
No, it was just, I was a little bit confused about, are we trying to estimate the proportion of female sex workers? You said at higher risk, but at higher, if they're infected and on treatment and suppressed, they're not really at risk anymore. But you presumably want to include those people in your higher risk. I don't know. That was.
Yeah. If
That's
someone
where I
is
got
already
stuck.
on the PrEP constantly, that in theory, the person is not at risk. But the thing is, because with service, like we are doing treatment, the demand is still there. We cannot just stop treatment ART. That's if we remove ART,
Yeah.
the person will die. If we remove the PrEP, that will get infected eventually. Some like a very high chance to get infected. So Sharon, just to maybe let's make this more understandable. That's you did this study in Namibia, and we
Yeah.
have a size estimation there, and the question from Jenny to me. So we have that estimate, that number there, and then we also have a number from Stepha's group that's with publication there to the small area estimate. So we have this two estimate set of numbers. And then which number we should use? That's the first question will come in. If we use this number, one of the number, should we use the total number or just use the part of that number? If there's 100 or 200, should we use 100 or 200? And when we decide to use 100, that set of estimate, and then we say this, in theory, it's not a 100, this should be all reached, but we should have this kind of the portion of that. So that is the question from Jenny to me.
Yeah. I mean, I don't know if Steph's estimates and the place estimates overlapped in terms of geography, because those, where we did the place studies, that was relatively small.
Yeah,
small
that's
places.
when we say the estimate, that's we always say that's either just we only like look at the subnational geographic areas, or as we say already have extrapolation to the national level. That second one is the usual case. That's when we say they always have during the funding request, they always have a way to have a kind of exercise as supportive document, Alex, to the
Yeah.
funding request. They already done some form of the extrapolation to that. So also the extrapolation part can be very tricky. That's so in that part, that's also when they come with big number and try to align with 1% or 2% of MS adult man being MSM, that one, that's number become really big. And then as when we do not have like a real other number or this with a clear understanding of this high risk portion, then people naturally just use that, start to do the gap analysis, start to set targets. So that is where the problem is.
Mhm.
Yeah, I mean, I think that this is a great example. So maybe I'll just say a few things. Like one of them is that the methods that we use for size estimation will affect like what proportion of people we want to consider from a programmatic perspective. So for example, like Wolfgang's giving this example where the size estimate in effect is about like people at venues. And I will say like, yeah, absolutely. Like the likelihood that there's higher risk in general among people at venues, wherever they're sampled, versus people in general, like all people, it's higher. It's higher, you know, just like that their baseline risk is higher. And so, you know, and then this, you know, what Sharon's saying, and I think is absolutely the case of like looking in Namibia and saying like, what kind of estimate a place survey would generate versus, you know, another approach that includes not just place, but like all the other epidemiological data that have been collected that is broader than people at venues and is intended to kind of like theorize all people in general based on a series of different approaches. I think, you know, the underlying math that you need to apply is different. So maybe just like, so two thoughts, like one, you talked about this as like there was some kind of urgency to the GC7, this process of like grant making. And so there was a thought about like, is there an approach that can be developed in the short term, thinking about like what was the underlying size estimation method that was used, and then having some sort of like adaptive approach to, and ideally a data driven one. So I'll just say ideally this isn't a guessing game, but where either, you know, we think about what the risk strata are, you know, one part, you know, at least one new partner in the last 6, like some sort of risk strata that makes sense. And then we look at all of our various data sets. Keith, the last time I remember us doing this was when we did the serosurvey work, that serosurvey paper in 2015 and 16, where we went to our various data sets and we looked at whether we had asked people whether they knew they were living with HIV, and then we also looked at the testing data. So like we came up with an approach, and then we went back to our data sets that we have access to and tried to kind of see what the data told us, because all of us have access to different types of data. So that like one idea is like, can there be some element, either leveraging the types of risk strata that we've used in the past, of just like a more immediate element of like looking at data and seeing what proportions look like? And I imagine they vary by setting and by place, and then or by population and by place, by setting. But then the second thing I think is this sort of like more nuanced downstream element where ideally we're doing this based on like the underlying size estimation methods, so that we understand that the more venue-based approaches will inherently push to a higher risk population than the overarching, like the underlying potential, like all gay men, for example, as compared to gay men at venues who are more likely to sell sex, or, you know, more likely to be sexually active with new partners, for, you know. And then also this idea of like dynamic, the fact that people go through seasons of risk, particularly around sex work, but I think in other communities as well. So I just want to say that, because I think we could get into the weeds on Namibia, but I think that's an example of like Namibia is like, if you're looking at venue-based folks, that's going to be inherently high risk as compared to including other estimates in there as well. Thanks.
Yeah, that's we I think we have moved to the right direction. That's because the background part I did not give just now. I should have given you guys. We all the countries, majority of half of the countries will send in their application. We call funding request, and we already have 2 windows, and it's, you know, already submit that. And a lot of countries will go to the grant making, really negotiate target and all the indicators on that. So we will need something that's, if there's ideally by end of this year, we can have some kind of more generic, if we have a percentage or proportion, that's a or that we have factors to consider against different methods, regional groups, something that can, at least we can inform the discussion in country, that's in the actual programming. A lot of, unfortunately, there's our key population program principal recipient are like civil society or this or community-based organization. Each round they always reshuffle the team. Always, this first half of the year, that's always this setting up team, put structure again. That's it's not like government structure. That's the Ministry of Health. So they already have people in place. Don't have like that level of turnover. Okay, so that's also a little bit. I want to talk more at the end of this call. We'll need to have some kind of timeline that's to come with something. Sharon.
Yeah, I was just going to say that you kind of suggested that some of the estimates were too high. So you're looking for how to make it easier for countries to reach their target. And another way to do that is relook at those estimates in the first place and see if they're too high, just flat out, and bring them down. Because, for example, in Mozambique, when we relooked at the estimates just now for sex workers, I don't know if you saw those numbers, but the size estimate came down by at least a third, you know, because they had previously come up with size estimates by doing a 1% or 2% or 3% of major cities. And when they actually then went to actual data, the numbers of sex workers came down a lot. So it could be that you get some countries where the size estimates will drop when they are more thoughtful about the size estimates, and that would help your problem of not having good enough coverage.
I know, see Toby. Toby, can
Yeah.
you talk if we can hear you?
Can you hear me? Can you hear
Yes,
me?
yes, yes,
Okay.
finally.
All right, great. Yeah, I've been able to hear everything. So, one thing I wanted to say is that I think that maybe getting the national size estimate ends up being a distraction because it's really hard to do, the extrapolation thing. So, and then I'm not really sure what we do with that, what we do with that number. I know all the countries, like they say they need a national number, but it feels like if we put more effort on the places where we know programming is happening and where we need to provide services and can get at some of these, maybe more different levels of risk and different services needed for different people, it would be a little bit easier. I don't always understand why that national number is needed or what gets done with that national number, except for like it goes in spectrum or something. But I think it is a distraction, really.
Yeah, I understand. But the thing, the global fund model always try to have national level impact. We always say that we're funding against national stretch plan. Although some of the stretch plan did not really address this key population component, but we still that's also there's and you already mentioned about modeling exercises. But the thing for us that's why we spend so much time really have extrapolation and keep investing in this.
But I do think we end up when we don't get we can't really use those local numbers because they don't add up to something realistic. So then we usually end up saying you need to use a population proportion for that national level. I think. I mean, that's been my experience.
Yes,
I don't know.
I know.
Right?
Many
So,
countries simple the population percentage to
yeah,
extrapolate.
because we say you have to measure whatever you're getting against that sort of norm, and then if you're totally off, you need to go with the norm. So therefore, some of the effort to do the extrapolation seems a little bit, like I said, a distraction.
Yeah, this come to the mind. That's also that's we talked already earlier. But there's a point that we may need to consider not only this estimation method, but also the extrapolation. What factors consider in the extrapolation? Sharon, I did read this what you guys come from Mozambique. I read that and I saw your name there. You're part of that. The thing that you see that as supportive document in the funding request. That exercise for the extrapolation and it come with number and then I just show that to Keith. There's a table that's there with all the national numbers there. So even in that number, that's sure we reach all of them in our grant. So that's the question. Jerry.
Thanks. So I was just thinking through a couple of the things, suggestions that had come up earlier, and trying to write down, how many definitions you might need. And I think, although I'm not deeply involved in programs, so I wouldn't be the expert on this, but you have people you want on treatment. That comes from Spectrum, right? People who are HIV positive. So that's check, the size estimate there. Then you have
Specific. Why are you talking? I'm asking Keith. Do we have key population specific on ART? That's a.
Oh, good. Yeah, good point.
We have it modeled. We just don't think it's very good.
Oh, right.
So, but
Okay.
there is a number that we don't use. But
so it's true. It doesn't come directly out of Spectrum. Okay. So, but people who would be in treatment, who you'd want to include for your treatment target would be in an IBBS or BBS survey, the percent are HIV positive. So that's a pretty easy one. Then for people you want to target with sort of a basic risk reduction approach, testing, condom use, those would be people who meet some basic risk criteria we can come up with. For MSM, it would be maybe what a lot of countries are using for PrEP, which is sexually active in the past, whatever, year, 6 months, with more than one partner. Or some, I don't have the definition, but we can come up with one. But we might agree that it could be pretty simple. Maybe has 2 partners and didn't use a condom with any partner in the last year. Something like that. If a country has a size estimate plus a survey, then they can do this, right? Multiply the proportion from the survey with the size estimate. The difficulty is always coming up, what is the proportion you multiply by? And I just think that for something like risk reduction services, whether it's condoms, testing, counseling, that underlying number is sexually active, with some unprotected condomless sex, some simple one-line definition that might even come, from a GAM indicator. And then I think the third one, so treatment, risk reduction, and then the third one is PrEP, right? And then we have a whole guideline on that. But you could probably erase half the guideline, because if I had to do it all over again, which I don't want to do, I would really just reduce it to a few pages. And then the part that gets thrown out is all this on how you define the risk criterion, right? This is what I'm talking about. So the risk criterion, we can just specify that, or you could just specify it as what I just mentioned, more than one partner, plus condomless sex with any partner in the last year. And then for PrEP, the only additional thing is HIV negative.
I like something simple. I like
That's
something
practical.
simple. Yeah. And I like something simple. That's I recall that, I don't know, Toby, you were part of that or not. That's in Cambodia, when we categorize the sex workers into high risk, moderate risk, and low risk. It's basically number of clients per week or per month.
Yeah.
So they have that very arbitrary. In a way, because my question to the group here is, if we come with something like, say, okay, based on these factors, we categorize, put the people into different strata, and how that will link with this actual program setting. And when this individual come in contact with the program, and outreach worker or peer educator say that you have 5 clients or this partners, you are classified as high risk. that kind of this process should be disconnected, or this should be should be the same in terms of factors considered in the criteria.
It's a simple differentiated service delivery approach that you have some sort of screening tool up front. It might be, depending on the services you're offering, you might need something more complicated. But if your services are more simplistic or very just straightforward, here are free condoms, here's a referral to testing, then you could probably use something pretty high level and simple.
Yeah, Steph.
Yeah, I mean, I think so. We have 10 minutes. I know it's late in the day for Wolfgang and others. I mean, I think maybe part of this is about, I think the simplest way forward, just in terms of like a short term, I would love like a really meaningful, nuanced, longer term process of advancing this. I'll just say this, and I would like it to have a dynamic nature to it, because I do think when you estimate, like, again, this idea of seasons of risk, I think that's more where some of the academic partners and others, I also like, I think, engaging Ian is the most the methods he applies are super interesting and always novel, and I love hearing him speak. He's such an innovative guy. I think, but I think so that might be also another stage of it, is this idea of like, how do you better integrate networks and network-based analyses into this? I think in the short term, I think as Jerry was saying, this idea of like risk strata, I just think of that process that that was led, Henry led it. I think it was like you and Henry and Wolfgang and others back in like the UCSF group asking this question about serosurveys, where we came up with some very basic things, and then we kind of took it back and did a number of analyses and then presented it back to the group, and then we ended up pulling it together and like kind of a table, and started asking this question about like, maybe there are commonalities in like what the proportions look like across settings or not. Like, I don't, ideally there's still a question there that needs answering as compared to it being predetermined of like it's 73.6% or something. And so I just think that like, I don't know if, I just think this idea of like setting just these basic criteria is, would be helpful in terms of moving things forward. So thanks.
Yeah.
All right, so let me just clarify. So you need something for Global Fund for these funding windows, or what's the timeline for your need?
Yeah, I like the way what Stefan just described. We will need to something that, because this timeline there, this GC7 will start, the actual ground negotiation and implementation will start from early next year. So we'll start. We will need to something immediate.
6 months.
Yeah, like 6 months, something. But in the email, I shared document. That's probably we may take a little bit long time, have more nuanced saying that's potentially a manuscript, because I like this manuscript style thing, because even internally, that's within Global Fund, I have a lot of debate. People have different level of understanding about this, and a lot of people, they appear they understand this, but in reality, they did not really put thinking into that. Either way, for me, to make my life easier, to have manuscript already published, say this peer reviewed, already published. You want to debate? Okay, let's debate on that. And because we have management structures, a lot of things, there's a lot of people that do not have even public health background, the bank or other things, why it's very, they are in power. So that's the thing. That's good. Why I said that. I do not have many peers at Global Fund, so I need the manuscript also. Need that kind of peer-reviewed publication on this, and then I can share with people. So in terms of like really steps, we need to come with something, and ideally UNS can publish that. If not, I will try to publish as the internal Global Fund guidance. That's because this probably UNS will need to take a little time.
Depends.
Yeah, so that's we will see. That's on this. That's but we'll need something. Try to imagine ourselves who will be applying this. I cannot be part of all conversations. It's not possible for me to. We have more than 100 countries with key population in HIV grant. There's more than 100 countries. Even as for the meetings, I cannot even attend all the meetings. So it's good to have something that people with some basic understanding can still apply. Of course, either way, just like a MSM guidance, 1 to 4%. That's very radical. That's anyone can say, okay, that's it. But the thing, it's not fair for many countries. That's on that. But the thing, if we have some simple, practical thing and say, okay, you have where to look for data. This IVVS data, the size estimation extrapolation, or the programmatic data, that we look for this specific variables. Based on this, that's we see, okay, this can be categorized here or there. So that let's start with that. Come up with something.
I'll also add that I think this is it folds into the direction that the modeling reference group was going. And the idea that they do want to capture key population data regardless of the model that's chosen within Spectrum. So having multiple risk groups and size estimates that could be folded in. So I think there might be a longer term process there as well that could get even further nuanced so that we get to where we want to go eventually. So we could have the short-term goal of something a little simpler and a longer-term goal that's more data-driven by country, you know, or even subnational region at a later date.
Of course, there's a subnational element. I know that I understand in our ground we have so much like issues around within the country. It's so diverse, even as between cities, big cities, small city, urban, rural areas, and migrate. That's between cities. That's this is so much more complicated than that. Sharon.
Oh, sorry. I had my hand up from a long time ago. I've forgotten. But I think I would rather, I like Jerry's idea of the strata being HIV infected versus non-infected. And then among those infected, what proportion are suppressed or whatever among those non-infected have your definition. I wouldn't go so much first thought on a higher risk versus lower risk sex worker idea, because I think if you tell people low risk sex worker, it just doesn't seem reasonable. It seems like an oxymoron to say low risk sex worker. So I would rather go for refining the definition of sex worker so that it's more like anyone who meets the definition of sex worker is a sex worker, and that means high risk. So some of these people that have pay for sex, once in a blue moon or get paid once in a blue moon, you wouldn't define them as sex worker.
Yeah, I mean, this is such an interesting conversation because I think like we're getting to the heart of it with like 2 minutes left, which is that like, because I it's interesting. I think of it as like higher needs and lower needs, but I do, it's interesting. But we have seen like a fair variability.
Demand generation.
Yeah, I mean, I think it's like like higher needs, lower needs in terms of like prevention services, treatment services among sex workers, because we definitely have seen some like variability in terms of HIV prevalence and et cetera, like based on different ways that they sell sex in terms of in streets, in brothel or in sex work venues, whether they, underlying income level, social determinants of health, et cetera. So that's interesting, Sharon. I mean, I think that's like, it's like an interesting conversation around, presenting that and thinking about it and just looking at the data in terms of what it's telling us in different settings.
I don't know if people have final comment because I will have a meeting in a few minutes. I'm sorry for that.
Yeah.
In terms of the next steps, that's we nominate Stefan Barrow to lead this and come. That means that's will be responsible to generate something. And we are all in this group. That's when we have this draft or something that we'll share with you for your comment. That's in terms of timeline, it's before end of the year. That's we have something that's can be communicated. I like the language, this demand or this kind of thing, probably need or this kind of thing that link with demand creation or other things. That's and also need to be neutral and non-discriminative. There's we always CRG department, this community rights agenda department always have different comments. That's so always and even come with something, I will still need to have an internal process to go through with that. So I'm going to share the recording of this session with Henry and with Yan. And you see that's even they cannot join the meeting, but we will share with them, still include them in the group. So. Any final comment?
The only thing that occurred to me is looking at this concept that Sharon and Steph just commented on was instead of incidence density, it'd be something like a needs density.
Mm.
That it would be over person time, because I'm thinking of the sex workers who work 3 months a year. You know, and if you do a size estimation when they're working, you get a higher number. If you do an estimation when they're not working, because it's off season, you get a lower number. And then you extrapolate that to the whole country and you're off by some factor. But if you did it as a density ratio and you say, well, this person who works 3 months a year contributes a quarter of a year to the size estimate, and you somehow configured it that way, it just, I haven't sorted it through, but that's what came to mind. So I'm just throwing it out there so it's in the recording.
Okay, thank you. Any final comment?
No, just
Okay.
just to say, I think it was something that we said we'd all be included. So maybe we'll talk about how to formalize that in terms of obviously getting Sharon, Toby, Jerry's, Wolfgang obviously is a CDC employee, but just like getting everybody's perspective, but just that it would like I might be administering or trying to move things forward, but that we would all be included in some sort of meaningful way. So yeah, we'll try to figure that out. Yeah.
Okay. So we can have a separate conversation about that to the administrative part.
Yeah, sounds great. Thanks.
Thank you so much.
Everybody, thank you.
Thanks.
Thanks.
Nice weekend.
Likewise.
All right.
Thanks a lot.
Okay.
Take care. Bye-bye.
Bye bye.